Dr. Ghouse, you're live, so you can
Yes,
start.
ma'am.
Yeah, you can start.
Yes, ma'am. Dr. Norman, can we have the slides, please?
Is the PPT visible?
Yes, sir. Can you put it to
Yeah.
slideshow?
Yeah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Very good morning to all the members of Global Dental Professionals. I'm Dr. Mohammed Ghouse. I'm an oral and maxillofacial surgeon based at Bangalore. Currently, I'm working as a full-time consultant maxillofacial surgeon. So, as we all know that today we have assembled here to learn about this enigmatic entity, which is, I'm pretty sure all of us have been hearing since our third year various times. So that is ameloblastoma, as all of you have guessed, and I'm very glad to be moderating this session. So before me introducing everyone to the speaker, I want to ask a question to all the members of this group as how can we contribute to diagnosing and managing ameloblastoma, since none of us directly involved in managing the pathology of the tumor. So what, as we dentists should understand, like how do we come to ameloblastoma as a maxillofacial pathology? Can we go to the next slide, please? So coming to the nature of lesion, even though ameloblastoma is considered as a benign lesion, but it is very aggressive in nature, invading the local structures. So we as dentists, we are often the first line of contact between the patient and the managing person. So if early diagnosis is not being done, this can lead to a more radical surgery, as that is the treatment choice for ameloblastoma, and that can lead to post-surgical morbidity. So early diagnosis is very important part of managing the disease. So coming to the clinical presentation as to how we can contribute to it is, since most of us in a clinic see more or less, I'm pretty sure that all of us have seen some painless swellings, which most of us, tag it to some pathology like a cyst. But sometimes this is not the case, and it could be a possible tumor for which we need to have an understanding that how to go about the clinical features and how to go about with the radiographical features. Suppose if we see the clinical features between a cyst and a tumor, a cyst more or less expands only one of the cortices, and most commonly that is the buccal cortice. Whereas in case of a tumor, there's more or less expansion of both the cortices, that is both buccal and as well as lingual. And often cysts, they present with a resorption of they do not present with resorption of adjacent teeth, whereas tumors, they can cause resorption of adjacent teeth. So this sort of basic understanding, if we have, then we can efficiently manage this kind of cases. Coming to the radiographic features that we see in a case of ameloblastoma, in a smaller multicystic variant of an ameloblastoma, we usually see a honeycomb appearance, whereas in larger lesions, we see a more or less like a soap bubble appearance. So Dr. Salman says there's no sound. Okay, am I audible?
Yes, doctor, you're audible.
Okay. Yeah, so there are various management techniques for ameloblastoma ranging from conservative to radical, but there's a lot of controversy in that. So the treatment options include going from basic diagnosis by doing a biopsy, then going ahead with curettage. Then people have also marsupialized the lesion, and there have been cases where people have done enucleation as well. But according to many articles and many authors, the gold standard for a multicystic or a solid variant of ameloblastoma is surgical resection. So we as dentists need to understand the various modalities available for treatment for this particular entity, so that if at all any possible complications of the procedure happen after in the post surgical phase, we should be able to identify it. So that is our effective role as in managing this lesion in a multidisciplinary fashion. Also, in effective communication, we need to understand this pathology because if we understand, then we efficiently can advise the patient as to what is the exact thing they are dealing with. And because as patients, they don't know anything about this, and the sole onus lies upon us that we need to make the patient comfortable, because then only he'll be willing to take the treatment. Then we also are the first line of contact, so we should be able to diagnose it very efficiently, and we should be able to make the patient understand what is happening in very simple terms. And also we need to make him understand what is the exact prognosis of this disease, what is the nature of the morbidity he's going to have, and what would be his life after the surgery, and what kind of follow-up he needs to be on. For this reason, as we dentists, we should be able to contribute in managing this pathophysiology in a multidisciplinary approach. So let me not delay more, and let me introduce our speaker for today. Next slide, please. So we have here Dr. Nouman Rashid. Dr. Nouman Rashid is a maxillofacial surgeon. So he finished his undergraduate from M.R. Ambedkar Dental College in the year 2017, following which he pursued his master's in maxillofacial surgery from the prestigious AIIMS Rishikesh in the year 2021, after which he went to pursue his fellowship in AOMSI, which was organized by AOMSI and Ganga Hospital, that is in Coimbatore, in maxillofacial trauma in the year 2021. Currently, Dr. Nouman is working as a consultant maxillofacial surgeon in Care Hands and as well as Florence Hospital in Srinagar of Jammu and Kashmir. So, yes, Dr. Nouman, you can take off from here.
Thank you for such a wonderful introduction, Dr. Ghouse. Am I audible?
Yes, sir, you're audible.
Yeah. So,
Can we have your video as well, Dr. Nouman?
Yeah, I'll just start. So, I'll be first thanking GTP Group and Gosia ma'am for letting me present this webinar on ameloblastoma, and thank my seniors, juniors, and our team here in Srinagar, Safe Hands, who helped me in planning the case and executing. So I'll be starting with today's topic, which is ameloblastoma, diagnosis and management. I'll be covering briefly, as we know, there are some dentists also here. So I'll just, as Dr. Ghouse pointed out, that ameloblastoma usually presents as an incidental radiographic finding. So its importance to general dentists is that they should be able to identify in the radiograph, as we'll be discussing once again. So to start with, beginning with the word odontogenic. So as we know, ameloblastoma is an odontogenic benign tumor of the orofacial region. So firstly, odontogenic means that it's a derivative of a tooth-related apparatus, and that it's derived from the budding tooth germ. As we can see, the enamel organ, which forms the tooth, dental papilla, dental sac, and this enamel organ, it begins with the invagination of the dental lamina from the oral epithelium, and soon after the enamel organ forms, this dental lamina disintegrates, but sometimes these islands of dental lamina persist, and they can be contributing to the formation of these odontogenic cysts and tumors. Before we come to ameloblastoma, we'll just briefly go through the tumor classification, odontogenic tumor classification, where classically it's been classified based on the tissue of origin. That is, it's classified into the tumors, those originate from the odontogenic epithelium. Those tumors which are also called as mixed, that is, those originating from odontogenic epithelium and ectomesenchyme, and odontogenic ectomesenchyme originating tumors. And we look to the ameloblastoma. It's classified as an odontogenic epithelial tumor, and it comes in this category. So classically, these tumors, odontogenic tumors, have been divided in these three subgroups. Now, if we look at the WHO classification, which was modified many times, and the most recent one was in 2017, that is the 4th edition, in 1992, 2005, and in this classification, in 1992, they had included the unicystic type of ameloblastoma. Now, if we look in 2005, the ameloblastoma was classified as into four variants: solid, multicystic, that is the classical one, then extraosseous or peripheral, then desmoplastic, and unicystic types. This desmoplastic was again reclassified in the 2017 classification as a histologic type, not as a clinicopathologic entity. Now, in changes in WHO 17 classification, if we go through this, it has been simplified because it has been narrowed, as I told, into ameloblastoma, then unicystic ameloblastoma, and extraosseous peripheral types. And the adjective solid or multicystic has been omitted from the conventional ameloblastoma to avoid confusion with the unicystic type. And desmoplastic, as I told, has been reclassified as histologic subtype. And odontoameloblastoma, which was included in 2005 classification, but was not included in 2017. As we know, the association between odontome and ameloblastoma is well established, but it was not thought to be included as an entity by the consensus group, because if we look at odontoameloblastomas, if there is a recurrence of odontoameloblastoma, they recur as ameloblastomas, not at odontoameloblastomas. And now they have been classified as ameloblastoma arising in an odontome, or not as odontoameloblastoma. Now, a brief introduction about ameloblastoma. As we know, amelo is derived from the ameloblasts, the cells producing enamel. And because these cells which are there in ameloblastoma in histologic examination, they resemble the ameloblasts. And as told by Dr. Ghouse, it's a benign, slow-growing neoplasm, but it's aggressive. So although it's benign, the treatment, since it's aggressive, the treatment, as we will see subsequently, is the gold standard is the resection, which we'll be doing. Now, people have given different classification, like Robinson has given usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. If we look back into the history, the first clinical report of an ameloblastoma was given by Cusack in 1827, and a detailed description was given by Broca in 1868. And earlier, its name was the term adamantinoma was given by Melasses for ameloblastoma, which is a Greek term which means very hard substance. And the term was later changed to ameloblastoma in 1934 by Churchill. Now, why ameloblastoma is important, as we are discussing today? Because it's one of the most common odontogenic tumors of head and neck region. Because if we'll see next to odontome, it equals or exceeds the combined total of odontogenic tumor in incidence. And if because it's more common. So if we'll see in North American studies, around 10% of all adenomatous tumors is ameloblastoma, and the incidence if in African studies is much more. Now, the origin of ameloblastoma, it can originate from the basal cells of oral mucosa or the rests of dental lamina, invagination of the lamina into the bone, or if it if it's occurring in the soft tissue as a peripheral ameloblastoma, again it originates from dental lamina rest or basal cells of oral mucosa. It can occur from the epithelial lining of odontogenic cysts as well, like OKC, and dentigerous cysts by ameloblastic changes in the cystic lining, and even cell rest of malices have been implicated by malices and then developing enamel organ components. Now, briefly about the pathogenesis. If we look in all the odontogenic tumors, there's if we look at the cell cycle, the most important phase is the transition from the G1 to S phase, in which if there is if there is genetic alterations in the oncogenes in this stage, so it can lead to either proliferation or apoptosis. Means when there is inhibition of the when there is activation of the or alterations of the alteration of the proteins which can initiate proliferation, there will be formation of these odontogenic cyst and tumors. Now, regarding PCNA positive cells, this positivity is more in case of unicystic and recurrent amenoblastomas when compared to the odontogenic cysts and other expression of the proteins as well. Now, recently, after 2014, after there was increased understanding of the pathogenesis and molecular mechanisms, these two pathways have been implicated in specifically in ameloblastomas. The mutations in the MAPK pathway, specifically of the BRAF gene, which is called as V600E mutation. This results in abnormal proliferation of the cells leading to ameloblastoma. And the other is the sonic hedgehog pathway, which is mostly seen in the maxillary tumors, where there is a mutation of the smoothened protein, SMO mutation. Now, if we'll see the variants, they are divided into a solid multicystic variant, which is the most common, and unicystic variant, unicystic ameloblastoma, and peripheral variant, which is the least common. Now, in the study done by Reichert and Philipson et al., which was a very large study, they found that 92% of cases it's solid ameloblastoma, 6% cases there's unicystic lesion, and 2% cases it's peripheral. Now, solid or classic multicystic ameloblastoma, it is the most aggressive type, and it commences as a solid intraosseous tumor within the bone, and slowly as the ameloblastic islands they proliferate, there's multiple islands, they join together and form the multicystic lesion. Now, as already told, this is a slow growing lesion, but has a local invasive potential, which is sometimes more than some of the malignant lesions of the head and neck, with a high rate of recurrence if not treated properly. Though it's slow growing, but requires aggressive surgical management, because even though it's slow growing, but it's aggressive and can perforate the bone. As Dr. Ghouse was telling, it can perforate both the cortices. Now, age range, it's seen over a wide age range, starting from the 3rd to 7th decade. Very less cases are seen in the 1st and 2nd decade, with a mean of 39 years. And there's no gender predilection. Most of the cases occur in the mandibular molar ramus area, in the 3rd molar or the ramus area, and maxillary lesions are also seen usually in the posterior region. Now, as I was telling, it has a potential of it's a very aggressive tumor with a slow growth, but the behavior is of a low-grade malignant tumor. Now, in the early stages, there are no clinical signs, and usually patient comes to a dentist with difficulty on eating or some pus discharge. So in that way, it's very important for us as dentists to diagnose these lesions early on the radiograph. Now, the most common clinical presentation is painless expansion of the jaws. So once the cortex is perforated, then the patient can mostly notices the swelling, and paresthesia is relatively uncommon, and pain, tooth mobility, and trismus can also occur in the later stages, and pain can be due to secondary infection or pressure on the peripheral nerves. Once the tumor perforates the bone, or it makes it very thin, there will be eggshell cracking of the bone, and which can elicit bony crepitus on palpation, and pathologic fracture in the later stages once the cortex or the lower border is perforated. Perforation is a late feature because the cortex acts as an effective barrier, preventing the spread outside the bone. Now, the radiographic features, there is considerable variation in the presentation of the solid multicystic type. Most of the times, it's a multi-locular radiolucency involving the entire molar ramus area, and with a typical soap bubble appearance or honeycomb appearance in some cases. But it can be unilocular as well. And once it's unilocular, it has to be differentiated with the unicystic type. And buccal lingual cortical expansion, as we were discussing, it's very common, but the perforation occur in later stages, and it has a well-defined sclerotic margin, as we can see in these radiographs, and that also points towards the slow growth of the tumor. And occasionally there is resorption of the roots as well, as we can see. Now, coming to the histologic patterns, the most common patterns are the follicular and the plexiform type, and there are some other variants of both follicular plexiform type, but most of the cases, these two variants will be seen histologically. These histologic subtypes, they have no role in the prognosis or the treatment options, or it doesn't affect the treatment, and these are just for histologic significance. If we can see in the follicular type, there is typical follicles, as we can see, of the polyhedral cells, in the center, or cells which resemble stellate reticulum, surrounded by the cells of the follicle, which are cuboidal or columnar cells, which resemble the ameloblasts, and surrounded by the stroma. And a lot of times there is cystic degeneration, which are seen in these follicles due to cystic degeneration of the stellate reticulum cells. Now, the next type is the plexiform type, in which the tumor cells are arranged as cords or strands with the intervening connective tissue stroma. And this network is, as we can see, is bounded by the cuboidal or columnar cells on the periphery, with the central stellate reticulum cells in between, and surrounded by the stroma. Now, the third most common type, around 11%, is acanthomatous type, in which is usually of the follicular ameloblastoma type, with the follicles arranged with the ameloblastic layer on the periphery and central stellate reticulum cells. In this acanthomatous type, there is extensive squamous metaplasia of the stellate reticulum with keratin formation sometimes. And next variant is the granular cell, in which the stellate reticulum is completely replaced by granular cells with acidophilic cytoplasm, which are cuboidal, columnar, or rounded in shape. And it is believed that these represent the cells as a result of phagocytosis of the neighboring stellate reticulum-like cells. This is the least common type, basal cell variant. In this, there is no stellate reticulum in the central portion of the nest, and which gets replaced by the basaloid cells. And the last one is the desmoplastic type, which requires spatial mention, as previously it was classified as the clinico-pathologic entity in the WHO classification, because it has a distinct radiographic as well as clinical features. So generally, it's not a radiolucent tumor, because there is high amount of collagenized stroma due to desmoplasia. And if we see regarding desmoplastic type, the first publication was by Eversole et al. In English literature. Earlier publications were there in Japanese literature, but the first one was Eversole in English literature. And there's extensive desmoplasia, as we can see. And regarding pathogenesis, as per Reichert, they are mentioned that as oxytocin fibers were present in the stromal tissue, cell rest of malices have been implicated in the pathogenesis. Now, as per Reichert, the histopathologic features of this type is that of a proliferating, irregular, often bizarrely shaped islands and cords of odontogenic epithelium of varying sizes in a desmoplastic connective tissue stroma. Now, again, this desmoplastic type begins as a painless swelling. It has been suggested that desmoplastic has a more infiltrative behavior than the conventional solid multicystic type, with mixed radiologic appearance in some cases. And as per Takata et al., the mixed radiologic appearance, that is both radiolucent and radiopaque appearance, is of this tumor is due to the infiltrative behavior. That is due to the infiltration of the tumor inside the cancellous marrow. There are some portions of the non-neoplastic, ameloblastic, non-neoplastic mandibular bone, which gets embedded within the tumor, which gives the typical radiologic appearance. Also, the infiltrative behavior Due to this infiltrative behavior, most of the times there's ill-defined border of this lesion. Now coming to radiographic features, again a unilocular or multilocular radiolucency with well-defined borders only in less number of cases, around 7% of cases, and mixed radiolucent radiopaque cases in a majority of cases with the resorption of tooth roots also, as seen in conventional ameloblastoma. Now, in the histopathology of desmoplastic, the islands are irregular in shape, pointed with a pathognomonic animal-like configuration of the epithelial islands. The cells, if we look at the periphery of these epithelial islands, they are cuboidal in shape with hyperchromatic nuclei. The cells at the periphery. Center of the epithelial islands, the cells are hypercellular with spindle-shaped or spermatoid epithelial cells. And sometimes they are foci of keratinization. And if we look at the surrounding connective tissue stroma, there is a profound desmoplasia of the connective tissue with thick collagen fibers which seem to compress the epithelial islands. Now, the treatment of solid multicystic type has been a source of debate in the literature for decades because some people, most of the authors suggest that it needs to be dealt with aggressive management. However, few of the authors suggest with the initial conservative management, and they reserve the radical surgery for persistent cases once it recurs. So, if we see the recurrence rates with the conservative treatment, it's 33 to 90%. So it's very high with the conservative treatment, and if we see with the radical treatment, the recurrence rate is relatively less. Now, those who support the conservative management, the first point they tell is that it's a benign process. So we need to deal with this like dealing with any other benign lesion. But once we look at the aggressive nature, though it's benign, but because of the aggressive nature, it has to be dealt with aggressive or that segmental resection for cure. One more reason for conservative management is because it's technically easier to undertake an enucleation or a curettage procedure than a resection. So that's why they have suggested. And one more reason is some authors suggest that conservative therapy is curative. However, which is not true because in most of the studies, the follow-up period is very less. And we know for ameloblastoma, the mean time for recurrence is around 7 to 10 years. So at least the follow-up period should be at least for 10 years minimum. And this confusion was further increased once Dr. Gardner published his paper on the behavior of ameloblastoma, where he stated that solid or multicystic variant does not invade the compact bone. He indicated that the clinical or the radiologic margins of the tumor are synonymous, which we know today that they are not synonymous. The radiologic or the histologic tumor cells may be way beyond the radiologic margins, and they suggested that compact bone need not to be removed, and as it tends to confine the tumor. But as we know, ameloblastoma often invades the compact bone in the later stages as well. And now if we come to the rationale for resection of the tumor, today it's gold standard for managing the solid multicystic type is to resect the ameloblastic mass and then reconstruct it. That is segmental resection with 1.1 to 1.5 centimeter margins. Now, why is this? Because this tumor is very aggressive, and subsequent curetages, repeated curetages, can result in persistent disease, and ultimately it can spread very rapidly, slowly, but it can spread to the especially in the maxillary tumors and the posterior mandible. It can spread to the infratemporal fossa or the cranial cavity, causing death. Now, why resection of the tumor is best? Because it tends to cure the disease. Because once the margins are adequate all around the tumor, there's very less chance that the tumor will recur. Now, as we already discussed regarding the conservative modality, the authors believe that it does not invade the cortical bone, but we know now that it invades the cortical bone as well. And ameloblastoma cells can be found up to 8 millimeters from the radiographic or the clinical margins of the lesion. So even if we enucleate or keratage the lesion, the ameloblastoma cells will remain in the cavity, and with a short follow-up of say 4 to 5 years, it will not be justified to call it as a cure if curettage is done, because the cells remaining there can lead to the persistence of the ameloblastoma. So in most of the cases, and there's also a debate whether we should call it as a recurrent ameloblastoma or a persistent ameloblastoma, because in the conservative management, the cells will remain there. So most of the cases are those of a persistence, so not actual recurrence. One more problem with the curettage is the tumor spillage during the enucleation or curettage. So ideally, it should, if ameloblastoma is managed with enucleation, it should not be, enucleation is a misnomer because it's not a cyst, and we tend to enter the cavity, and there's tumor spillage. Now, as we can see, ameloblastoma can spread intracranially and retroorbitally in these cases. So now, is there a role for enucleation of this tumor? So in solid multicystic type, the ideal treatment for the gold standard is to resect the mandible with 1 to 1.5 centimeter of margins all around. And in case of the perforation of the cortex, one soft tissue layer also has to be, uninvolved soft tissue layer also has to be involved in the resected mandible. But enucleation in case of a unicystic type, enucleation can be done. But in case there is a mural unicystic ameloblastoma, on histopathologic serial examination, if there is a mural type, then the management again changes and we have to resect because the mural type is again aggressive. Now, enucleation and curettage can be done in case the patient is medically compromised or very young or old patient who is not willing for segmental resection. Now, this paper was given by Eric Carlson in JOMS in 2006, where they've explained about why primary surgical management is important, and it's curative in nature because the entire ameloblastoma tissue has been removed. Now they have explained the steps during the surgical management to cure the lesion. First is the assessment of the anatomic barriers, which has to be done on CT or the radiographs to assess if there is any violation of the anatomic barriers. The first barrier is the cortical bone, which is an effective anatomic barrier to check if there is any perforation of the cortex. Then after cortex, the periosteum, muscle, submucosa, mucosa, and the dermis. Once the ameloblastoma perforates the cortex, it rapidly spreads to the other areas, muscle, submucosa, mucosa. However, the skin remains as the effective barrier for spread of the ameloblastoma, and in most of the cases, the ameloblastoma does not perforate the skin. The reason being because due to its slow growth as well as the high regenerative capacity of the skin remains intact in most of the cases. Now, after anatomic barriers are assessed, the second is the resection of the tumor with bony margins of 1 to 1.5 centimeter, linear bony margins. As we know, that tumor extends 2 to 8 millimeters histologically beyond radiographic borders. Then after resection, use of specimen radiographs intraoperatively inside the OT once the patient is under GA, and assessing the adequacy of the margins, whether margins are okay or less than 1.5. If the margins are less than 1.5 centimeters, then if the margins are less, then there is option of frozen section, whether the surgeon will send some bone marrow, some cancellous bone for frozen section to analyze in case need additional resection. So according to Carlson, there is no role of conservative measures like curettage in management of solid ameloblastoma, and resection of 1 centimeter bony margins has to be done, and soft tissue margin of 1 uninvolved anatomic barrier. Suppose there is perforation of the bony cortex, you have to involve the periosteum or the surrounding muscles to effectively prevent any recurrence. So the patient is cured when all soft tissue and hard tissue margins are negative. Now, according to anatomic location, also we need to assess, especially in the posterior maxilla, because the maxilla is a very spongy bone, and in the posterior maxilla, the tumor can rapidly spread to the sinus, infratemporal fossa, and to the cranial cavity. So the posterior maxillary tumors are much dangerous and need aggressive resections to cure the disease. So this was an algorithm given by Pogrel to manage ameloblastoma based on the size of the lesion. Like if the lesion is small, curettage and cryotherapy can be done with a follow. The only problem with this algorithm is they don't take the histopathology into consideration while formulating the treatment plan. Coming to the unicystic ameloblastoma, also known as cystic ameloblastoma, ameloblastoma associated with dentigerous cyst or cystogenic ameloblastoma. It was first described in 1977 by Robinson and Martinez in 20 patients with unilocular cystic lesions, where the morphologic features were similar to that of ameloblastic epithelium. So, while describing unicystic ameloblastoma, we have to understand the distance between unicystic and unilocular. So, the unicystic ameloblastoma refers to both macro and microscopic appearance. Because it's a cystic lesion with the ameloblastic epithelium on the periphery, it's a monocystic lesion with the ameloblastic epithelium on the periphery, the cystic cavity inside, and the unilocular, which refers to the radiographic appearance of the lesion on the radiograph, um, which there is only a single locule or a single locule of the lesion, which can be also the unilocular can be also solid multicystic ameloblastoma. So there is a difference between unicystic and unilocular, and we have to carefully use the words while describing unicystic ameloblastoma. So, cystic ameloblastoma has been suggested by Regesi et al. For unicystic ameloblastoma, because occasionally there is also a multilocular unicystic ameloblastoma. So they tell that it's better to call it as a cystic ameloblastoma. So most of the cases, as we can see, is in the molar ramus region with involvement of the tooth. And if we see a critical review of unicystic ameloblastoma, in which 193 cases were studied by Reichert, the unicystic ameloblastoma can be divided into two categories. One is the unicystic type with an unerupted tooth, also called the dentigerous variant. And some unicystic cases are those in which there is no tooth involved, also called as non-dentigerous variant. Now, if we compare unicystic with the multilocular or solid type, these type usually are seen in young patients in the predominantly in the second decade, and more that of the dentigerous variant, which is seen in the second decade. Non-dentigerous variant can be seen later also, and 90% of cases are seen in the molar ramus region. And differential diagnosis is that of a dentigerous cyst or an OKC. So it has to be clearly evaluated. And most common radiographic presentation is a well-defined unilocular radiolucency, which mimics a dentigerous cysts. Some authors suggest that there is the tooth is not within the cystic cavity, but there's a displacement of the tooth from that of the unicystic ameloblastoma. Now, pathogenesis, there is some controversy, as some authors believe that it exists, it originates from pre-existing odontogenic cyst, while others believe that it originates de novo without any odontogenic cyst, like authors like Ackerman and Lai et al., in which Lai et al. Had evaluated the PCNA positivity of the unicystic type, in which he found that the unicystic type of ameloblastoma has more of the PCNA positive cells as compared to the dentigerous or other cysts, other odontogenic cysts. And there are three mechanisms which have been proposed by Leiter et al. First one is the reduced enamel epithelium, which undergoes the ameloblastic transformation and subsequent cystic development. Second one is from the pre-existing odontogenic cyst or dentigerous cyst, in which the neoplastic ameloblastic epithelium is temporarily preceded by non-neoplastic epithelial lining. And third mechanism suggested is solid ameloblastoma undergoing cystic degeneration of ameloblastic islands with fusion of multiple microcysts developing into a unilocular cystic lesion. In 1992, Unicystic ameloblastoma was added as a distinct clinical entity, and the minimum criterion for diagnosing Unicystic ameloblastoma was suggested to that of a single cystic sac with ameloblastic epithelium, usually present only in focal areas. So, in case of a unicystic ameloblastoma, the entire cystic lining is not that of an ameloblastic epithelium. It can resemble radicular or even dentigerous cyst also. Now, classification of unicystic ameloblastoma was given in 1988 by Ackermann into type 1, 2, and 3, in which the type 1 is the ameloblastic epithelium within the cyst wall, within the cystic lining. The type 2 intraluminal type is the proliferation of the ameloblastic epithelium within the cystic cavity as a papillomatous mass, which most of the time is a plexiform unicystic ameloblastoma. And third type is that of a mural type, which is found in the murus or the connective tissue wall of the unicystic ameloblastoma in the cyst wall. And later this classification was modified into modified Ackermann classification, in which subgroup 1 is luminal, subgroup 1.2 includes both luminal and intraluminal, which is also called as plexiform unicystic ameloblastoma. Subgroup 1.2.3 includes 1.2 plus a mural proliferations, and subgroup 1.3 includes luminal and intramural ameloblastic proliferations. So in all of these, the mural ameloblastoma, which is seen in the cystic capsule, is the more aggressive form, and its treatment is different from that of the luminal or intraluminal type. As we can see, this is the plexiform unicystic ameloblastoma of the luminal intraluminal type, and this is the histologic presentation of the mural. Usually nodules are seen in the cystic wall, as we can see here, and in most of the cases there is cystic degeneration of the follicles, ameloblastic epithelium follicles present within the mural ameloblastoma. Now this is the Vickers and Gollins criteria, 1970, in which they presented the early features of ameloblastic epithelium when there is transformation from odontogenic epithelium. So these features are the early histopathologic features of neoplasia as per the Vicker and Gorlin criteria. First one is the basal cells, which are cuboidal or columnar shape. Second, nuclear hyperchromatism. There is nuclear palisading and reverse polarization of the nuclei away from the basement membrane, and cytoplasmic reticulation with intracellular spacing. Now coming to treatment of unicystic ameloblastoma. Now if we see when we do a pre-operative incisional biopsy, so it's not always that it will be diagnosed as a unicystic or a mural type, because for unicystic ameloblastoma, the gold standard is that once we remove the entire cyst, we have to look for the proliferations or intraluminal or mural proliferations within the entire cyst wall. So there has to be a good coordination between the oral surgeon and the pathologist regarding the same. And some authors even have suggested to abstain from incisional biopsies, but sometimes we have to do because to rule out other pathologies like OKC. But once we have removed the entire cyst or the cystic lining, then we have to look for the mural or intraluminal proliferations. If after enucleation there's only luminal or intraluminal proliferation seen, then the enucleation what has been done will serve as a curative treatment. And if there are some mural proliferations within the cyst wall or some nodules within the capsule, so one option is that we can follow up the patient indefinitely and look for any recurrence of the tumor, or if in cases or there is other option to plan for resection for the mural ameloblastoma, because the behavior of this type is similar to that of solid multicystic ameloblastoma. Now, some people have suggested the use of cornite solution for chemical cauterization of the surrounding wall, and what they have noticed is the less lower recurrence rate as compared to the without using the cornite solution. So the recurrence rate, if we see, is much lower than that of a solid tumor. According to the Robinson-Martinez series, it's about 25% recurrence rate following curettage. But that included the mural type also. If we look only at luminal or intraluminal type, the recurrence is about 10% following curettage. For intramural even, it's about 35.7% recurrence rate. So it's much higher, and it has to be dealt as we are dealing with a solid ameloblastoma. So the problem here is that most of the papers do not separate the mural variant from the less aggressive luminal or intraluminal variants. So because of the inclusion of mural variant in the cure rates, it negatively impacts the cure rates and the recurrence rate. So, so prospective studies need to be done where these three are separately identified and differentiated and followed up. So when to resect unicystic ameloblastoma? So when, as per Peterson, when there is a recurrent unicystic ameloblastoma following an enucleation or a curettage procedure. So second one is the mural ameloblastoma. Resection has to be planned. So some authors have suggested that the resection margins can be as less as 0.5 to 1 centimeter as compared to the solid type. And in case of a large tumor, when there is possibility of pathologic fracture of the mandible or bone. Now, briefly about the peripheral type, it was this type is found in the extraosseously in the gingiva or the alveolar mucosa. It was described by Curer in 1911, and it's most rare variant. And usually it doesn't invade the bone, and usually it's of a smaller size. And there can be sometimes cupping out of bone on the radiographs. And the treatment is simple local wide excision of the peripheral type. We can present one case of unicystic of the ameloblastoma, conventional ameloblastoma. This one patient reported to our dental OPD with complaint of difficulty or discomfort while chewing on left side of the jaw in the back tooth region since 2-3 days. So there was no extraoral swelling. Patient didn't know that he had ameloblastoma. So it was just an incidental finding on the IOPF. So there was a radiolucency well defined just below the third molar region. And subsequently, we did an OPG and we found that the entire mandible was hollowed out with a multilocular radiolucency extending from the second lower left premolar to the entire ramus, excluding the condyle. Patient didn't had any nerve paresthesia or any crepitus, bony crepitus, and there was some mobility and some pain on pressing on the third molar tooth. These were the CBCT sections showing the hollowing of the mandible in all the three sections. The good thing was condyle was intact, and we planned for the incision biopsy intraorally, which was done in September last year. And on the incisional biopsy, the strange thing what we found was while we were removing, the consistency of the tissue was very hard. It was like a freezed ice cream like consistency, as has been described in literature for desmoplastic type. And few bits of tissue were removed and sent for histopathologic examination. And it was found out to be of desmoplastic type. So for planning the resection, we used a 3D model to plan and preoperatively bend the recon plate on the model to save the time. And the recon plate we used was a locking recon plate with locking screws. Now these were the steps of the surgery, which was undertaken 1 month later. And these are the markings about 2 centimeters below the inferior border. And skin, subcutaneous tissue, and platysma was incised. And within the deep fascia, we can see the facial vein is there, which along with the facial artery were ligated and divided. This is the facial artery. And after ligation and division, the flap was reflected upwards, protecting the marginal mandibular nerve, and which was followed by identifying the lower border and giving the periosteal incision or the periosteum anteriorly and or the pterygomacetrix link posteriorly. And subsequently, the subperiosteal dissection was done to expose the entire lesion from the sigmoid notch till the opposite parasymphysis. Plate was adapted before resecting with non-locking screws in the segment, and the anterior cut was placed along the premolar and posteriorly along the sigmoid notch, and then the mandible was removed after division of the neurovascular bundles. So after this, the closure was done. This is the resected specimen of the mandible and post-op X-ray. So this was the final biopsy report suggesting desmoplastic ameloblastoma, and the both anterior and posterior borders were free of the tumor. This was the histopathology. As we can see, again, the classic animal-like configuration of the epithelial islands. These are the animal-like configurations of the epithelial islands squeezed between the dense collagenized stroma, surrounded by the peripheral thereof cuboidal or columnar cuboidal cells. So this is the post-op healing after 3 months, both intraoral, extraoral, mouth opening, and occlusion was satisfactory. This is after 1 year. Patient has a good mouth opening of 45, and occlusion is also satisfactory. So these are the lateral movements of the mandible. This is after 10 months.
Sorry to disturb you, Dr. Nouman. Your slides are not changing.
Yeah.
After 1 year post-op, your slides weren't changing.
Yeah, this was the last slide.
Yeah. Okay. Excellent presentation, Dr. Norman, on the enigmatic topic of ameloblastoma. You started from simple things like how do we diagnose it, what are the clinical features, which include the expansion of cortices and the soap bubble appearance which we see. You
Yeah.
also explained the recent WHO classification where they omitted the term solid or a multicystic variant completely, where where they modify they brought out better terms such as conventional ameloblastoma and unicystic ameloblastoma, thereby reducing the confusion amongst all the practitioners. And also the paper where Pogrel had described about the size of the lesion, where it was less than 1 centimeter, greater than one. The algorithm where they used a conventional radiograph to manage, if it's less than 1 centimeter, go for a conservative, and if it's greater than 1 centimeter, take a CBCT and then check if there's perforation and things like that. Also, the paper by Eric Carlson, where he summarized the entire surgical management, which includes, how conventional ameloblastoma has to be dealt with. That is, in short, he has told that radical resection is the gold standard for management, where he has also mentioned the importance of perforation in the cortex and how cortex acts as an anatomical barrier. And all and you especially deep very well summarized the concept of unicystic ameloblastoma and its histological variants, and how these affect the treatment planning and the prognosis, where the mural variant has more is more aggressive and greater chances of recurrence. So in short, I would tell this was an excellent presentation, Doctor. Thank. And the participants we are open up for discussion. Any questions or anything? We are encouraging you, and it can put in the chat box, or if you're more comfortable, you can directly speak to us. Thank you. Any questions from the participants?
Anyone who wants to add something?
Hmm. Dr. Norman, what is your experience with unicystic ameloblastoma? And also, I would like to add on, like, what is your experience with the conservative mode of management? Have you had an experience with that?
Conservative management, I uh, don't have an experience, but unicystic, yes, for that unicystic, we can undergo enucleation, because most of the cases, once there is a unicystic lucency in the ramus or the third molar region, the most common differential diagnosis will be that of an OKC, which has to be treated with enucleation. So if the lesion, there's no perforation of the cortex to such a level that there can be post-op pathologic fracture of the mandible, so yes, it can be managed with enucleation. But in case it's a solid lesion from beginning, the management has to be aggressive. Aggressive in the sense that it has to be a segmental resection with 1 to 1.5 centimeter margins, and soft tissue also in case there's a perforation.
Suppose a same case in probably a much older patient, somewhere around 70s, comes up with a solid multicystic variant.
Yeah.
Would you think of a conservative approach in that, if at all?
Yeah, in those cases, if the patient.
Can I just interrupt and ask Dr. Nouman to stop sharing his slides so that we can
Yes,
get the
Yes, sir.
discussion going?
Yes, sir.
sure.
Yeah.
Yes, Dr. Nam.
Yeah. So, in case the patient is medically compromised or he's not fit for general anesthesia, so in those cases we can do a curettage.
Curated. But again, we should be able to explain it to the patient that there are high chances of recurrence, is what
Yeah,
you're saying.
we have to explain. We have to explain.
That is.
Even in case of
Also,
infection, also we have to explain that there's chances of recurrence, and we have to be at least for 10 years. We have
follow-up.
a close follow-up with the patient, because follow-up is very important with these patients.
Dr. Noman, in such cases, what do you think could be the source of, any origin of recurrence if you have any, where you have resected the mandible adequately with 1.5 centimeters of
Yeah.
margin and you're very sure that there's been
So,
no perforation or anything like that?
in those cases when there is adequate bony margins and 1 to 1.5 centimeter margins, and on histopathologic examinations the margins are free of tumor, then the possible reason can be the uh, perforation of the cortex, either buccal or the lingual, from where the tumor would have spread into the soft tissues. So in those cases, it can be equal to more or less like a curettage only, even though we have resected the margins from both the sides, but because of the soft tissue involvement, it will behave same like the recurrence will be same like that of a curettage.
You're right.
Yeah.
Excellent. Excellent. Dr. Raman, could you please elaborate on the role of biopsy, especially in cases with unicystic ameloblastoma?
Yeah, biopsy, if we see, it's very confusing, especially in case of unicystic lesion, because once there is a unicystic lesion, some people, as I was telling, some authors suggest that pre-operative biopsy is of no use. But I would
True.
like to disagree, because sometimes it can be an OKC also,
Hmm.
or other lesion also. And so pre-operative biopsy has to be done if the lesion is very large. So pre-operative biopsy has to be done. And after that, once the lesion is completely, even though the lesion is uh, diagnosed on a pre-op biopsy as a dentigerous or an OKC, there can be
Hmm.
some islands of ameloblastic.
Ameloblastic changes.
So it has to be, there should be a close coordination with the pathologist, and the
Hmm.
entire specimen should be examined properly for any proliferations of the ameloblastoma.
Suppose you've decided to do a initial biopsy, which is incisional in nature, and
Yeah,
you have sent it for histopathology, where they have said they've not specified that there are some ameloblastic changes going on, or what variant of unicystic is this. And you go ahead with complete so enucleation of the lesion and send it for histopathology, and you close off the surgical site,
yeah,
and you find out that this was a mural variant,
yeah,
and you haven't underdone a resection, as well as you haven't used any of adjunctive procedures which you mentioned, that let it be carnoid solution or cryotherapy.
yeah.
So in such case, how would you like to go ahead with managing that condition?
If we have not used carnies or any other adjunctive, then better would be to go for a revision, or to
Hmm.
explain to the patient that there's a chance of recurrence later, and
Hmm.
later we might need to reoperate,
Hmm.
keeping the patient under close follow-up. But what I feel, resection will be better in those cases.
Resection would be, but
Resection.
the pathologist also has to be well trained for you to tell that
Yeah, yeah,
this could be a mural variant.
that's very
That,
important, because
that is very important, because our sole treatment lies on that.
sole treatment lies on them, and even close coordination is also very important, because it's also important that we give clues to the pathologist also, because it's not only one way. We also have to give clinical and radiologic clues, because some surgeons, they just give it to the pathologist and they tell you have to diagnose, but without giving other clues like clinical and radiographic, it's very difficult for diagnosing it correctly. So yes, it's very important for
So in,
pathologist to know
yeah.
what
So in
he has.
that case, just pray to God and keep the patient under close follow-up so that recurrence doesn't occur.
Yeah,
That's the only thing we can do is what I feel.
because resection, again doing another surgery.
Yes, because the
Yeah,
patient has already undergone a
already
procedure and
undergone. Yeah,
to
very close follow-up is needed long term.
at least of 10 years,
At least 10 years. Some cases have recurred even after 40 years. So close follow-up is very necessary.
So what do you think is the role of, uh, you couldn't, in a conventional ameloblastoma, suppose you couldn't, for some reason, you couldn't do a resection in a
Yeah.
conventional, not a unicystic variant, and you decided to go ahead with the conservative method of curettage and all sorts of those things. And uh, is there a role of adjunctive procedures in that, such as peripheral ostectomy or carnoise or therapy for that
Yeah,
matter?
that has been tried.
Would that increase the prognosis?
If there is, if we are not in a situation where we can't do a resection, uh, if we don't have a surgical setup or the skills, or if the patient is not willing for the procedure, or if the patient is medically compromised and we are planning for a conservative modality, then it has to be supported by adjunctive modalities to improve the chances of it. And morbidity will be less, as we know, with a conservative treatment, but it will not cure the lesion.
Yes.
Ultimately, maybe the patient will live another 5-10 years happily without any morbidity in the function. But later we don't know whether it will recur or not, and we have to explain the patient, and adjunctive procedures should be done in those cases, especially
Uh, mm,
if any lesion is there within the bone. There is no cortical perforation, any unicystic lesion, which can be either OKC, ameloblastoma, that has to be routinely followed so as to be on the safer side. If we are doing, especially if we don't know the preoperative diagnosis in case of a smaller lesion. Hello? Hello? Hello?
Yeah, I think Dr. Gauss's network issues.
Yeah, but I was telling, if there's a small cyst completely enclosed within the bone on all the sides with no cortical perforation, and in those cases, it can be any type of cyst. So in those cases, once we are directly doing the excisional biopsy without knowing which type of cyst it is, so we can use the adjunctive procedures like peripheral ostectomy, removing the portion of the bone with the round burr, or adjunctive procedures like corneal solution cryotherapy to prevent a recurrence.
We have lost Dr. Gauss's connection.
Yeah.
I'll just connect to him and get back. He's trying to get back to us.
Yes.
But excellent presentation, Dr. Nouman. And it was nice that you added your case as well.
Yes, ma'am. Thank you, ma'am. It was the first time, so I
Yeah.
was also a little nervous. And if any other person wants to add something, any seniors, because we are also learning. So, anyone is there to add some points?
Joining back, Ghouse. Hello.
Hello. I think Wi-Fi connection has been lost with Dr. Coles.
Yeah,
He was just telling.
I have informed him, doctor.
Yeah, he was just telling that his
Yeah, we
Wi-Fi
got him
connection.
back. We got him back. Yes. Okay.
Yeah.
Yeah, okay. Yes, Dr. Gauss, you can take over. I think there are no more questions, so we do the conclusion. Hello, Dr. Gauss? Yeah.
Hello.
Yeah, you can conclude it, doctor. Yes, doctor.
Am I audible, ma'am?
Yes, audible. You can conclude it, doctor.
Am I audible?
Yes.
Power had gone.
No problem. No
Sorry, no, Dr. Nouman. Yeah. So as we were talking about the role of, as Dr. Nouman rightly stated that he anyone would not like to do that in a case of ameloblastoma because there are high chances of recurrence. And in short, I would like to say that ameloblastoma is still an enigmatic entity in terms of surgical management. There's high chances of recurrence where both conservative where there's only conservative mode of management has been utilized. There's a chance of recurrence up to 30%, which was explained by Dr. Nouman. In short, that surgical method is a more preferred approach to a case of ameloblastoma. But however, in conditions where the patient is medically compromised and is, he cannot undergo a procedure for some reason, curative intent is conservative management is one method where we can manage this, but again we have to be very clear with the patient about the recurrence and possible treatment outcomes. So Alhamdulillah, this was a great webinar, and I got to learn a lot, especially from Dr. Nouman, and I'm very thankful for that. I'm also thankful to all the members of GTP group, and I'm especially thankful to Dr. Kaushya ma'am for giving me this opportunity to moderate this session. Saying all of this, after saying all this, I would like to conclude the session. Thank you very much. Alhamdulillah.
It was a nice session. You moderating the session, and Dr. Gosia ma'am also there to support, and really thankful to the GDP group for letting us do this webinar.
Thank you. We end this session, doctors.
Yes, ma'am. Okay.
Yeah, Jazakallah khair.